G'day pandemic nurses, and welcome to this session on high flow nasal cannula. My name is Danica and I am a CNE at Nepean Hospital Intensive Care Unit. During this COVID pandemic, we're seeing a lot of high flow therapy amongst these patients, and this session is a basic overview of high flow, particularly for those staff who are currently working out of their area of expertise. And we really do thank you for coming to help us look after these patients. So talk about what is high flow therapy and its benefits, indications for use, setup, monitoring and escalation, cares and troubleshooting, and weaning. So we have a range of oxygen delivery devices at our disposal, and if we look at this picture as a sort of a spectrum, these devices increase from flow and oxygen delivery capabilities from low to high. So the use of high flows of gas in high flow therapy result in the generation of a small amount of PEEP, so positive end expiratory pressure. And this is the pressure that splints the alveoli open and improves gas exchange. So high flow therapy acts as a bridge between the low flow oxygen therapies like our normal nasal cannula, Hudson masks, and our non-invasive ventilation such as CPAP and BiPAP at the other end of the spectrum. FiO2 versus flow. So FiO2 stands for the fraction of inspired oxygen, and it's measured as a percentage. So room air is made up of 21% oxygen. So room air has an FiO2 of 21%. Flow is the volume of a gas delivered, and it's measured in litres per minute. Peak inspiratory flow is the fastest flow rate during the inspiratory cycle. So being a type of flow, it's also measured in litres per minute, and it's a measure of the patient's inspiratory effort or work of breathing. So normal's around 20 to 30 litres a minute for an adult. In times of acute respiratory distress, this can go up as high as 120 litres per minute. Now, starting with low flow oxygen therapy via normal nasal prongs, if we applied a flow of 4 litres of oxygen to a patient, based on the patient's average peak inspiratory flow around that 20 to 30 litres a minute, an oxygen flow rate of 4 litres will give an FiO2 of around 36% in the patient's breath or tidal volume. Now, the gas coming out of the oxygen tap or flow meter is 100% pure medical grade oxygen. If the patient was only breathing in oxygen from the flow meter, they will be receiving an FiO2 of 100%. This isn't the case though. So when we use low flow nasal prongs, what makes up the patient's breath or tidal volume is a combination of the 100% oxygen coming from the nasal prongs plus the air that the patient's also breathing in from the atmosphere around the nasal prongs to meet their peak flow demand. So this is because conventional nasal prongs don't provide enough flow on their own to meet the patient's peak inspiratory flow demand, and this is where high flow nasal prongs come into play. So high flow therapy delivers warm, humidified, blended gas at high flow rates that meet the patient's respiratory demand, which reduces oxygen dilution and also generates some positive airway pressure. So this is a cute little mnemonic that I didn't create, that I came across, and I think it summarises the benefits of high flow therapy quite nicely. So H is heated and humidified. So humidified gas preserves the mucociliary tract. It assists with the removal of airway secretions, and it can enhance patient comfort. So some patients will find the humidification a bit hot. Depending on your device, there's a little bit of room to move with the temperature, but by all means turn it down, but don't turn the humidification off when you're using high flow. I, inspiratory demands, for adults you're looking at around a flow setting of about 30 to 60 litres per minute. So the high flows are aimed at equaling or bettering the patient's inspiratory flow demand, and this is going to help improve their breathing pattern by increasing their tidal volumes and also decreasing their respiratory rate. F, functional residual capacity. So increases in functional residual capacity or end expiratory lung volumes is likely due to a small amount of PEEP that's generated by the constant high flow of gas into the airway. PEEP enhances oxygenation, like we said, by splinting open those smaller airways and alveoli, preventing atelectasis, and allowing continuous gas exchange throughout the respiratory cycle. It also decreases the work of breathing, as a patient doesn't have to generate as much pressure to reopen collapsed alveoli. L, lighter. So the nasal prongs are actually softer and more pliable than conventional nasal prongs. This can help with patient comfort. Patients can eat and drink freely. They can communicate better with high flow nasal cannula in situ, which means therapy is less likely to be interrupted, and patient compliance is generally higher with high flow nasal prongs compared to your low flow mask or your NIV mask. O, oxygen dilution. So it prevents oxygen dilution by wearing nasal cannula suited to the size of the patient's nares. The high flow rates meet the patient's inspiratory flow demands. Oxygen dilution is decreased, and the FiO2 is precisely controlled. And lastly, W, washout of dead space. So dead space is air in the airways or lungs that does not partake in gas exchange. So high flows help to wash out the nasopharyngeal dead space. It improves ventilation and oxygen delivery as less CO2 is rebreathed by the patient, and comparatively more oxygen-rich air is transported to the alveoli. Indications for use. So high flow nasal cannula are intended for use on spontaneously breathing patients. There are a number of indications, and the main one is acute hypoxic respiratory failure. So these are your community-acquired and viral pneumonias, pulmonary embolism, cardiogenic acute pulmonary edema, asthma. It can also be used for pre-intubation oxygenation, and this includes, as well as leaving the cannula in situ, for apneic oxygenation during laryngoscopy as well. Other indications: post-extubation, assistance with secretion clearance and humidification, do not intubate or palliative care settings, post-cardiac surgery, invasive procedures, and there's some pediatric indications as well, mainly bronchiolitis in peds. The contraindications include severe hypoxemic or hypercarbic respiratory failure, and we'll talk a bit about escalation further on. And then conditions where positive airway pressure could have adverse effects on a patient as well. So setting up high flow nasal prongs. There's multiple ways that you can deliver high flow oxygen depending on the delivery device. The equipment required and the setup will differ slightly. So a basic setup like this uses flow meters, oxygen tubing, and a little Batman connector where it connects onto the top of the humidifier and the oxygen tubing. So essentially all setups, you'll need a humidifier and heated inspiratory circuit, a bag of water for injection for humidification, high flow nasal cannula, and of course an air and oxygen supply. Beyond those, depending which setup you're using, you also might require an air and oxygen flow meters, oxygen tubing, and an air oxygen blender. If you're connecting flow meters, ensure that you're using high flow meters if your patient's requiring higher settings than 40 and 40. So a 15-litre oxygen flow meter will max out at these settings. A high flow oxygen flow meter can deliver up to around 60 litres per minute, as opposed to the 15 litres per minute that a low flow one will. There's numerous devices that can deliver high flow. I've included the 3 machines in our unit that we use, which are the Airvo 2, which is specifically for high flow. It can deliver flows up to 60 litres with an FiO2 of 100%. We also have the Respironics NIV machine and our ventilator as well, which has an oxygen therapy option on it as well, and this just utilizes the inspiratory limb of a ventilation circuit. I'll just run through the setup of an Airvo 2 because that is a very common machine that's around for high flow. So first connect one end of the oxygen tubing to the oxygen inlet port on the side of the machine. Then connect the other end to your oxygen flow meter at your oxygen source, and remember to use a high flow oxygen flow meter if your settings are greater than 40 and 40. The water chamber slides into the front of the machine and connects to the chamber ports, and you need to give it a good push and make sure it's in there nice and tight. So to insert, push on the finger guard, slide the water chamber across the heater plate and into the chamber ports so that they connect. Connect the water spike up to the bag of water for injection, and the water chamber will automatically fill in the correct amount of water. You don't need to squeeze the bag or do anything fancy. The heated breathing tubing is specific for this machine. It only connects in one way, and you simply push it onto the heated breathing tube connection port on the top of the machine. The other end of the heated tubing connects to the patient interface, and in this case you can see that we're using high flow nasal cannula. Other interfaces you can connect to in this particular system are high flow tracheostomy and a face mask as well. The machine hardware is now set up for use. So turn the machine on, let it perform its startup check, and then you can enter your settings. So the machine will immediately start heating the water chamber. To set the flow or temperature of the water, use the mode key to scroll through the parameters that you want to set, for example, the flow. Then hold down both the arrow keys for 3 seconds, and it will select flow, and then you can adjust the setting using the up and down keys and finalize your setting by pressing the mode key again. To set the desired FiO2, you don't do this through a machine, you do this through your flow meter where your oxygen tap is. And the amount of oxygen that you dial up will depend on the amount of flow that you have set, because remember, the more flow you have, the more oxygen dilution you have. The Airvo 2 will deliver a max of 60 litres of flow per minute. In terms of fitting the nasal cannula, this fitting guide shows you how to get the most out of them. So picture 1 there, select the appropriate size. You want nice snug fitting nasal prongs in the nares, but the patient still needs to be able to breathe around them. So there should be a visible gap around each prong. Picture 2 there is looking at reducing the risk of pressure injuries. So try and fit the head strap a little higher on the head, away from the ear. And then picture 3, tighten the head strap, but don't over tighten it. And you might want to check for pressure injuries under that as well. Pictures 4, 5, and 6, looking at using the clips on the head strap. So you've got the head strap clip and you've got the clothing clip, or you can position the tubing to relieve its weight so that it doesn't pull the cannula out of the nares. To help increase patient compliance, ensure that you explain to the patient that high flow cannulas are stronger and warmer than normal nasal prongs. This comes with multiple benefits, and you can chat to them about it if they need more answers or reassurance. So setting flow and oxygen. You'll need a medical prescription for settings, so I urge you to refer to your local protocol for guidance on that one. When individualizing to a patient though, consideration goes in this order. Number 1, you're going to set the flow first. So essentially your flow is going to help decrease work of breathing and improve oxygenation. CO2 washout occurs around 30 litres a minute of flow. Flows greater than 35 litres a minute have a PEEP effect. So the higher the flow, the higher the PEEP effect. At flows of around 60 litres a minute, there will be about 5 to 7 centimetres of extrinsic PEEP developed. Keep in the back of your head, this PEEP will drop to 2 when the patient's mouth is open. Number 2, once you've set your flow, you then set the oxygen flow or FiO2 to target the desired peripheral oxygen saturation level. So you're probably looking about an SpO2 of 90 to 96% that you're aiming for. It will depend on your patient though and their history. So for example, a COPD patient, you're going to aim slightly lower than that, maybe 88 to 92. It's not unreasonable to commence your oxygen at an FiO2 of 40% and then titrate around that. After you've set your initial flow and your oxygen settings, review your patient for their response. So you might need to increase the flow by increments of 5 or 10 litres per minute, and the oxygen as well if the respiratory rate, the work of breathing, or the oxygenation hasn't improved. So depending on your setup, you may need to use an air and oxygen flow meter guide. You will only use this table if your setup utilizes both oxygen and air flow meters. Equipment like the Airvo 2 or the ventilator won't require this table, but I'll just quickly run through it in case you've got a basic setup. So just as an example, you've got a prescription of 40 and 40, so you've got a flow of 40 and an FiO2 of 40. You will need to set your airflow to 30 litres per minute and your oxygen to 10 litres per minute, okay, to equate to an FiO2 of 40%. Looking at the purple Airvo table on the right, I just want to point out something. The more you increase your flow, the more it dilutes your oxygen. So if you look at that 15 litres of oxygen column, you move from 63% down to 45% FiO2 as the flow increases. All right, so, and that's where your high flow meter is going to come into play there to maintain that FiO2 at a higher level. So monitoring and escalation. So patients requiring high flow nasal cannula can be at high risk of severe respiratory failure or risk of becoming intubated. So they require close monitoring in the acute phase of their respiratory illness. Monitoring and documentation will depend on your local protocols. However, after commencement of high flow nasal prongs, it's not unreasonable to assess the patient 1 to 2 hourly and record the following parameters. So what are their settings, and then in relation to those, their respiratory rate, their SpO2, the humidification temperature. You also probably want to see an ABG, particularly in the hours after commencement, when escalation in settings is occurring, and also for monitoring CO2 in hypercarbic patients or comparing the SpO2 in patients with darkly pigmented skin. When starting high flow, ensure that a detailed management plan for review and escalation is documented and you've got something to follow and refer to. You may have a patient that cycles between high flow therapy and non-invasive ventilation, and this can make it a little bit more difficult to observe for deterioration at times. But essentially, if your patient is needing to spend longer on NIV and desaturates more frequently and for increasingly longer periods on high flow, then that would be a sign of escalating care and deterioration. So it's really, really important to communicate escalating oxygen requirements. Sudden increases, they might be due to additional diagnoses such as PE, APO, or MI, particularly in COVID patients, as these are known complications of COVID. Deterioration just from their primary diagnosis may occur over hours or days. At the end of the day, early escalation and review shouldn't be delayed, especially for those patients who are already at the maximal end of their high flow therapy. And we're seeing a lot of COVID patients that are sitting on high levels of flow and FiO2. So patients exhibiting signs of deterioration on the right here are at high risk of requiring intubation. And again, looking at these signs of risk, communication, review, and planning are key to keep these patients safe. Cares and troubleshooting. So high flow nasal cannula are not particularly labour intensive. Some basic cares and troubleshooting to consider are regular skin inspections, so around the cheeks and ears where straps are coming into contact with the skin. Check for any skin breakdown or pressure injuries. It's always good practice to check around the nares as well. You can put some protective dressings on if required. Check the nasal prongs for mucus soiling. Give them a clean if they're soiled. They do get a bit goopy. If you need to give nebulizers, these are generally given over the top of the high flow nasal cannula using a nebulizer mask. Also be aware that the circuit humidifier chamber should be changed at some point. Again, this will just depend on what you do locally, but it's likely to need to be changed after about a week. The most common troubleshooting occurrence is kink tubing. So airflow ceased if the tubing or nasal cannula become kinked, and that most often it's due to drag on the tubing. So ensure the tubing's adequately supported with those clips, and it's not pulling sideways on the nasal cannula across the patient's face and kinking the prongs up against their nares. Lastly, mobilization or transferring of a patient may require a change in your oxygen delivery device. Depending on your setup, you may not have battery backup or transportability for your high flow therapy. Weaning. Weaning will come from the direction of the medical team. The patient's physical examination, chest x-ray, ABG will all inform this decision. When weaning from high flow therapy, wean the FiO2 first, because remember we're aiming for the lowest required FiO2 as possible, and the flow also assists with the weaning of oxygen. So when the FiO2 is down to about 30%, then wean the flow down as required. When the flow is around 20 litres per minute and the FiO2 is 30%, you should be right to safely swap the patient over to conventional nasal prongs. Take-home points. So the use of humidified oxygen has immediate benefits for the patient's airway, including the preservation of their mucociliary tract and secretion removal. High flow therapy uses a combination of oxygen and flow to achieve improved oxygenation, decrease the work of breathing. High flow meters are required for settings over 40 and 40. Don't forget. Ensure that you've got a plan for your high flow, that it's documented, including your settings, plan for review, and definitely plan for escalation. And later on, when the patient is recovering, you need a plan for weaning. Monitor your high flow therapy closely. Communicate any concerns early regarding escalating oxygen requirements or signs of deterioration, or just if you're generally worried about the patient. Try and use the lowest FiO2 possible to meet their oxygen targets. Avoid hyperoxia where able, and typically you're going to aim for 90 to 96% SpO2. Very important during COVID, remember to utilise airborne infection control precautions where required, as this is an aerosolizing procedure. And if you need more help to understand oxygen flow and FiO2, OzMed has a short CPD session that you can access at this address. So, like anything new that you come across, speak up, ask questions if you don't understand what's going on, or if you're just worried with what you see. I hope this was helpful. Don't forget to like this. By the bedside. Take care, guys.